Hello, my name is Nicola.
Hello, my name is Niv.
Welcome to our presentation on our online DBT group for people with learning disabilities. Just to give you a little bit of information about DBT, so DBT stands for Dialectical Behaviour Therapy and was developed by Marsha Linehan back in 1993. The aim is to support people to reduce life-threatening and self-harm behaviours. It helps individuals to learn behavioural skills, to problem solve, to manage extreme emotions and to help them manage difficult interpersonal relationships. There are 4 modules in DBT: mindfulness, emotional regulation, which we call coping with feelings, interpersonal effectiveness, which we call people skills, and distress tolerance, which we call coping in crisis. So the COVID-19 pandemic has obviously presented many challenges, but it's also for us presented a real opportunity to extend the reach of our psychological interventions to vulnerable populations through remote learning. As you probably know, adults with a learning disability are at increased risk of experiencing mental health difficulties, and the pandemic has certainly exacerbated this. In particular, we were hearing from people where they were expressing feelings of distress, feeling overwhelmed, feeling high anxiety, and people talking about, the loss and lack of connections with others as being a real difficulty for them. Welsh Government were certainly emphasising to us for us to continue to provide the best mental health support that we can, and the British Psychological Society was highlighting the need for us to adapt psychological interventions for people with learning disabilities. So we had already been running a face-to-face DBT group for many years, very successfully in the community. And we'd already adapted the DBT model to a programme of face-to-face groups. We use the I Can Feel Good resource, which helps to think about the needs of people with learning disabilities in thinking about the different skill areas. And with the online group, we ran weekly online groups for a period of about 12 months through 2020-2021.
Okay, so how we made our online groups more accessible to our service users. So prior to the start date, we set an individual sessions with each of our service users just to go through the technology and kind of get familiarized and ready with what the group is going to look like, and just to normalize and make it more less anxiety provoking. We open a group 15 minutes before the actual start time. And that was for people to come and have a casual chat, maybe non-DBT related, and just bond and gel. We shortened the group. We used less materials in each sessions, but the group ran for longer. So like Nicola said, the group ran for 12 months. We were much more physical in our teaching. We were much more using props and make our teaching as fun and interactive as possible. And I'm going to quickly try and demonstrate one of the props that we use. So I'm going to disappear and come back in a second. Okay, so hopefully everyone can see that I got a magnificent red wig, and this is just one of the props that we use to illustrate the different sets of minds in DBT. So red we use for hot mind, we use a blue wig for cold mind, and then we use a purple wig for wise mind. It's just to help the service users get familiarized and consolidate and remember those skills that we taught them in the group, which was really helpful.
So the benefits of what we found in terms of the benefits of the online versus face-to-face group. So with the online group, service users spoke more openly about challenges in their lives. They often spoke more about how they applied their skills and how they generalised their new skills into their lives, maybe because they were doing the online group at home in their normal environment. We were able to focus more on each individual on screen, and also strong and meaningful relationships were created, both from the facilitators with the participants and amongst the participants themselves.
So just some feedback from our service users. So generally, they stated that the group was positive. It helped some with accessing the group. So for example, travel-wise, they didn't necessarily have to travel to our one of our facilities. Some stated that doing a face-to-face group would have been too anxiety-provoking for them, so they prefer the online option. Fun activities helps learning new skills. People enjoy connecting to and with others. On the other side, some services that did not finish or did not complete the group stated that they needed more support from their carers. And some also stated that the group was too long for them. So 12 months was a little bit too long for them. So just a quick couple of examples of how our guys wonderfully generalized skills into their own life, especially mindfulness. So we talked about mindfulness and the origin that comes from Buddhism, and one of our service guys actually bought a couple of Buddha statues and put it in his backyard, and he's practicing mindfulness outside of the group on a regular basis. Another service users used one of our mindfulness exercises and adapted to his own interests, which is Doctor Who, and used the TARDIS as to illustrate better for him that particular mindful exercise. So it was really, really wonderful to kind of see how they adapted and how they generalized and how they took it outside the group and into their everyday life. So some learning points from the digital context. So smaller groups help to put theory and practice into everyday life. Mindfulness was the most enjoyable and popular module of DBT. On the base of that, we are now running an 8 weeks online mindfulness group. Our attrition rate was high. So part of our outcome and feedback measures, we're going to ask our service users if whether face-to-face group would have been better for them, if they would prefer that over the online group.
So in summary then, the online group we do realise doesn't suit everyone, but there were lots of people it did work well for, particularly those individuals who experience social anxiety and who struggle in group situations, and those individuals who were confident with the technology and were much more familiar with using technology in the online sort of world. We did feel that accessing the group from home meant people were able to generalise the skills more easily than perhaps the face-to-face groups, which obviously improved effectiveness and ultimately their well-being. The pace of the materials covered was slower compared to our face-to-face groups, but we had increased awareness of the difficulties each individual group member faced. The group was more accessible to some individuals, so practically, those people who couldn't travel to a face-to-face group were more able to access it. And as we said, psychologically, people who perhaps had difficulty coping in group situations. So going forward, we feel that the experience has shown us that both online and face-to-face groups are important to improve inclusion for this vulnerable population, and it is something that we want to certainly continue to offer as a hybrid of both online and face-to-face groups to ensure that there is good access and options for individuals with a learning disability. And that's the end of our presentation. Thank you very much for listening.
Thank you, everyone. Okay.
Thank you for taking the time to listen to my presentation today. I'm going to share with you briefly the work that I was involved with this year, contributing to a GP cluster. The North Cunnin GP cluster in Rhondda Taff decided to recruit a dietitian to support them with their work with chronic conditions. And I started in post on the 1st of February. I can give you information of how the project has gone over the past 10 months. I have access to the vision system that the GPs use. I share the notes, I write in the notes, so everyone is kept up to date. I offered 35 new patient appointment slots each week, which are each 40 minutes long. I could also offer early appointments and late appointments to suit people's needs. Another benefit of the frequency of these appointments and the number of appointments was how regularly I could contact people. And this was really important when it came to behaviour change and making lifestyle change. I am a member of the Motivational Interview Network of Trainers, and every consultation takes a motivational interviewing approach. There were a mixture of consultation styles or abilities. I could use telephone, video, face-to-face, and also home visits when necessary, mostly for undernutrition. I also delivered motivational interviewing training for the cluster staff, and I'm just completing the second set of training for them. So to give you some idea of the referrals I received, the bulk of referrals were for chronic conditions, with a smaller number in undernutrition and gastro. The weight ranges being referred with chronic conditions, 76 kilos to 281 kilos. Another benefit of being within the surgery and people having access to my booking system is that people could be seen very quickly. So 74% of patients were consulted within 2 weeks of the discussion with their healthcare professional. Due to limitations of people having access to scales at home, and not many people coming into the surgery, there are recorded weights for 36 people. There was a range of weight loss between 0.4 kilos and an impressive 45.3 kilos. And the mean percentage weight loss was 5.5%, which does show improvements in long-term health, reduction in heart attack and stroke. Looking at the HbA1cs, these could be recorded in 12 people, and the mean reduction was 18.5. There's also reported outcomes that couldn't be captured, particularly for those people who couldn't weigh, and these were significant to them. They had a huge impact on them and how they felt. You could see improvements in sleep patterns, self-confidence, and certainly for a lot of people becoming less self-critical and forming a more healthy relationship with food, where it doesn't become a comfort or a way to manage stress or trauma. People were questionnaires that used the service, and there was a very strong feeling from all of them that they felt more hopeful about reaching their health goals and felt more confident about being able to improve their health. Another important part of lifestyle change is sustained change, and everyone who was questionnared intended to continue with the changes they had made. Some comments that come back from the questionnaires that people really valued the service. My primary goal when I consult with anybody is to engage with them and to work together with them. And this certainly came back in the comments that people made in the questionnaire, but also to their health professionals. Dr. Claire Woods, one of the GPs within the cluster, has kindly taken time out to share their thoughts and hopes for me being part of the service, and also their impression of it. So I'll share that with you now.
So as a cluster, we wanted to appoint a dietitian to try to develop services locally to support our patients. We identified that there were quite a few chronic conditions that were related to a raised BMI, such as fatty liver, polycystic ovarian syndrome, metabolic syndromes, diabetes. And actually these conditions were over-investigated, over-medicalised, and were often treated with medications rather than any kind of psychological or other interventions. We also didn't really have anything in place to help support patients with obesity. So we recruited a dietitian who would have the time to support our patients locally in an attempt to ideally reverse some of these conditions or improve the outcomes in our patients. So Orla was appointed to the position, and it was really great to see that she wanted to start group consultations, and also that she specialises in motivational interviewing, both things that are evidence-based to support patients in behavioural changes, and they're effective ways of kind of enabling patients to have a sustained change within their lives. And not only were we kind of like looking at the measurable outcomes, but also we wanted to have a look at, you know, were these behaviours kind of sustained? So actually the outcomes of the patients that Orla saw, there's a significant benefit to having a dietitian in primary care. Just the measurable outcomes, including weight loss, reductions in HbA1c, it just exceeded our expectations of what would happen within such a short space of time. But actually there was a huge amount of positive feedback from patients about their experience and about the approach that Orla had taken in helping them with their chronic problems. And I think this has essentially just led to a more sustained behavioural change and enabled the patients to just have better well-being. And essentially this leads to healthier decision making in patients, happier patients, who kind of take some more responsibility for their own health, which is something which I think a lot of people, especially after COVID, have struggled with. And therefore, obviously, this leads to healthier patients and hopefully a reduction in chronic diseases, or at least some kind of reversibility or stopping the progression of some of these chronic conditions such as diabetes. And essentially, we all feel really strongly that having a dietitian in primary care is essential in helping supporting patients in their chronic disease management, and especially as a huge amount of these are linked to diet-related problems, and the motivational interviewing is a really positive way of helping our patients.
So thank you for taking the time to listen today, and also thanks for the opportunity to share this work. Thank you very much.
Hello, I'm Louise. I'm the Clinical Lead Speech and Language Therapist for Hywel University Health Board, here today to talk to you about my experience of setting up a virtual family group for those families in the community that are living with acquired neurological communication difficulties. And the personal inspiration that encouraged me to set up such a pilot group was recognising in my everyday clinical practice that it is these family members that are holding everything together, and that we needed as a therapy service to widen our spotlight to include these family members more routinely in our interventions, as they are the ones that are self-managing these conditions for those with cognitive communication difficulties that aren't able to self-manage the condition by themselves. In addition to the personal inspiration, I also noticed that there was a wealth of public health data out there also supporting the need to target family members. It was recognising how much of a chronic health symptom communication difficulties are, with up to 60% of those having language difficulties after 6 months, and the risks, the public health risks of not including family members in our therapeutic approaches, whereby care isolation and lack of social connections being a comparable risk factor for death as smoking 15 cigarettes a day. So yeah, a significant health risk if not included. Additionally, internal service audit information showed that these family members, or those individuals with family members needing to support them, were spending longer and longer on the caseload or being re-referred back in to the service. So clearly having an unmet need not being targeted. So if that wasn't through family complaints, then we were getting the speech language therapists themselves asking for support to manage these family members who weren't quite getting it or were presenting as a challenge to them in some way. And recognising that there was an unmet need there were groups out there for the individuals themselves, but not the family members, or there were groups out there for non-communication related needs, but not communication. So bringing those two unmet needs together. And of course, impact of COVID has meant that these family members, bless them, have been managing these conditions in even more of an isolated way than ever before, and with increased responsibilities to care for them sooner than they did prior to COVID. So yeah, that also highlighted the need for such a group to exist. And of course, the evidence base around family-centred interventions are widespreading and very well established as to how they can impact and benefit the wider health service and the individuals themselves. as does the evidence base for group-based interventions, which is long established in how that can improve the outcomes for therapy services. And the overall aim that we wanted to achieve from setting up a pilot group such as this was to develop resilient families who can meet the communication needs of the individual with less reliance on us as health professionals. So in order to do that, we set up a robust screening questionnaire so that we could select the family members who were going to most benefit from such a group. And from that, 6 family members were chosen, and the content and structure was designed to suit the needs of the family members and what they wrote in the screening questionnaire, together with what we were seeing in our everyday practice as an unmet need that needed to be targeted. So they were sent pre-outcome measures, and then their sessions were delivered via Microsoft Teams with bookings. And then at the end, they completed the same measures and feedback forms. The resources included a clinical lead SLT, a specialist SLT, a therapy assistant practitioner, administrative support, and a lot of time and energy, which was challenging at times, but well spent in the end. Here is a brief overview of the session content. And as you can see, there's a big psychosocial education theme running across all the session content, with the first 2 being heavily focused on education and establishing shared expectations of what the recovery and rehabilitation journey looks like in respect of communication difficulties. And then the second half of the content focusing more on living with communication difficulties, compensating for them, and then recognizing to learn how to look after themselves better. And yeah, the last session was a wellbeing check for that reason, and encouraging them to signpost themselves to third sector organisations and other local community services, so that the peer support benefits from this group kept on being achieved at the end. The structure was a co-produced effort with the family members that were interested in attending. This particular group were available on Thursday mornings, and they wanted it for no longer than 6 weeks. So we did it for 2 hours every Thursday for 4 weeks, and then the last one an hour, but it could be organised any which way the family members would prefer. So if they wanted it one big chunk or lots of little ones, that could all be slotted in with the content that was already designed. The tools and skills, yes, there was a PowerPoint presentation, but to avoid death by slide, there was also a workbook, which included tasks they could do within and outside the group. The Microsoft features, such as the chat, polling, and breakout rooms, really helped establish the peer support and connections. Being able to talk to each other without therapists there at times was useful. And the main speech therapy skill, which is often undervalued and underused, is the active compassionate listening, which is our bread and butter, and was kind of the main ingredient skills to achieving the successes that we had within the group. So just to summarise, if you can imagine the magic happening, I know Halloween has just passed, but if you were putting in a helpless isolated carer into the witch's cauldron, mixing it up with some compassionate active listening, opportunities for peer support and some education, out came the magic of a resilient family. But how did we know that we had a resilient family at the end? Well, the adult carer quality of life scores in the following areas all increased, which are great for them being able to achieve that ability to care for a condition by themselves. And 100% of the attendees had an upward change in score for how able they felt to manage communication difficulties after the group. And these were the lovely comments that we had either during the group or in the feedback forms, with the general theme of the family members feeling less alone, more supported. And one of them said, listening to others has been calming, really helped me cope. So that is also how we knew it worked. Other outcomes that we weren't expecting but happened nonetheless were less travel time and costs because it was a group and virtual, therapist satisfaction of working in this new way, skill development of those within the group that needed to use those skills working with families outside of those sessions, and general awareness raising of the scope of us as a profession to work in this way. I'd really like to see where I could take the group in the future, adapted for other conditions and settings, for example, look at how the wider impact of the group makes a difference, whether it be to the number of family complaints, re-referrals into the service, etc. and what I just touched upon with regards to looking more at the competency development part of it. So yeah, thank you so much for listening, and I look forward to hearing your comments and questions.
Hello, my name's Claire Butler. I'm a speech and language therapist seconded into Welsh Government as National Speech, Language and Communication Coordinator.
And I'm Catherine Pape. I'm also seconded into Welsh Government as National Speech, Language and Communication Coordinator.
Talk With Me is Welsh Government's Speech, Language and Communication, or SLC, delivery plan.
The plan was developed in collaboration with the Royal College of Speech and Language Therapists. It went out for consultation in spring 2020 and was launched in November. It consists of 5 objectives, all with measurable outcomes that we'll explain a little bit more detail. Speech, language and communication skills matter because they affect people across their whole lifespan. We know that up to 50% of children living in poverty might start school with speech, language and communication needs, which then may impact their emotional and mental health. We also know that 88% of long-term unemployed young men have speech, language and communication needs. The aim of the delivery plan is to ensure that all children in Wales have access to high-quality, universal, population, targeted and specialist support in the early years to develop their speech, language and communication skills, with the ultimate aim of improving health and well-being of children, families and populations in Wales.
Objective 1 on the delivery plan is about raising public awareness of early speech, language and communication development. The main work for this objective at the moment is around a publicity campaign called Talk With Me. The first phase of that campaign will launch on Monday the 29th of November. You'll be able to see the resources on our campaign page, www.gov.wales/talkwithme. We'll show you an example of some of the resources now. This poster shows the 10 Talk With Me key messages, based on the most recent evidence about what helps to support children with their SLC skills. Here's an animation which will be part of the campaign to illustrate one of the key messages. Objective 2 of the delivery plan is to improve the identification of speech, language and communication needs, or SLCM, in children aged 0 to 4 years 11 months. We've procured a piece of research looking at the evidence for screening and the available early identification tools. The plan, following the outcome of this research, is to either adapt or to develop a suitable tool for the Welsh population, which will be available in both Welsh and English. The third objective is to provide evidence-based interventions for speech, language and communication. We're procuring a piece of research which will review the SLC elements of available interventions for parenting and infant and perinatal mental health, as well as looking at specific SLC interventions at universal, population and targeted levels. This will ensure that appropriate evidence-based SLC interventions will be offered at the point of need in order to improve SLC skills and reduce the risk of SLCN impacting on children's development and well-being. The fourth objective on the delivery plan is around upskilling the workforce in relation to SLC. So far, we've focused on the childcare workforce, and we published an SLC training pathway for practitioners working with children under 5 earlier in 2021. We're also looking at training for the health visitor workforce and at pre-registration content for both health visiting and initial teacher training, as well as working with the fostering and adoption workforces to try and help them to address their SLC training needs. Objective 5 is to embed speech, language and communication across Welsh Government policies. We've been working with colleagues who are responsible for developing the new curriculum, the ECEC or Early Childhood Education and Care Quality Framework, as well as there being commitments in the 5th objective around youth justice, employability and skills, and additional learning needs.
Research has shown that the COVID-19 pandemic has had a significant impact on children and young people's development, particularly their speech, language and communication skills. We've worked with our colleagues in Welsh Government to support their response to the COVID-19 pandemic. For example, we've ensured that the Child Development Fund has a focus on speech, language and communication, as well as on children's gross and fine motor skills and their mental health and wellbeing. We've also supported specialist speech and language therapy to manage the anticipated increase in referrals. We're currently working to develop the next steps of the delivery plan to ensure sustainability. Thanks so much for listening. Do get in touch if you want any more information or visit our campaign page.